This is your mini lecture on controversy number 4. Should we retain health care for older people? Americans over the age of 65 account for 1/3 of all national health care expenditures. But rationing health care on the basis of age alone is troubling to most Americans, and perhaps some of you even cringed when we started on this topic of rationing health care for older people. How can we justify spending large amounts of money prolonging the lives of older adults? Who will get access to expensive healthcare resources? Let me tell you, these questions do not have easy answers. So if you're struggling with this topic, you are not alone. Has rationing healthcare ever been done before? Is it likely to be introduced in the United States? Here are some examples in which a form of rationing healthcare has been done. In Britain, kidney dialysis has been routinely withheld from people over the age of 55. In Canada, for some procedures, like non-life-saving surgeries, it may be necessary to wait long periods. In Seattle, hospitals used to have special committees that decided who would have access to dialysis. In Oregon, for healthcare problems covered by the state's Medicaid program, funding is available and services are rationed not according to individual cases, but according to a consensus reached by a democratic means and a computer-based ranking of severity. So it has been done before, and it has been done in the United States. There are also ways to ration healthcare besides age. These include a person's ability to pay, anticipated clinical effectiveness of the care, waiting lists, first come, first served, and the person's productivity to society or their social worth. After hearing this list, it may seem that rationing based on age might actually be better than trying to figure out if a person has worth to society. After all, if we did ration on age, it would be more efficient to administer. Older people are less productive in the economy, and all people are members of every age group at some time. So again, if we rationed based on age alone, that may be the most fair across the board because everybody ages, regardless of other factors in their background. It's difficult to determine how much money would be saved. The majority of money spent on healthcare goes to prescription drugs, nursing home care, and home health services. The rapid rise in healthcare costs is solely due to longevity. The rising healthcare costs are also due to increases in intensity and rates of utilization of whatever healthcare we're talking about, the introduction of new medical technologies, the rise in real wages of healthcare personnel, general price inflation, also fraud, waste, abuse, and futile medical treatment, or providing medical treatment even though we know it's not going to work. A big part of this debate about rationing is based on economics. So economics is the science of scarcity. Only when we have scarcity is rationing actually seriously considered. The oldest old, so those are people over the age of 85, have the greatest number of health problems and cost the most in terms of health care. So if expensive healthcare resources were rationed on the grounds of age, as philosopher Daniel Callahan recommends, then this age group, the people over age 85, would be denied healthcare. How do you feel about that so far? We often end up spending more and more money to achieve small gains, usually with a remaining poor quality of life, while other social needs go unmet. Callahan, who I mentioned before, believes that society owes older adults a decent minimum of health care, at least up to a certain age. Critics of Callahan argue that age-based rationing actually affects only those who depend on government-run health care programs. That is, of course, older people who can't afford private care. But Callahan believes we already have an invisible form of rationing in place, and it would be better just to make it overt and public, rather than hidden and invisible. There are some possible alternative approaches to rationing, such as limiting medical procedures based on the effectiveness of those procedures as measured by actual health outcome research, Or we could do cost-benefit analysis, which means determining how much a treatment costs in comparison with the total benefit that'll be created if the patient lives. We can also do cost-effectiveness analysis, or looking at which treatment provides the desired outcome for the least cost. Or we can use something called quality adjusted life years, QALY. This is the common sense view that 10 years of life with disability may not have the same value as 10 years of good health. So these are some of the arguments that have been put out there, both in a favor of and opposed to rationing healthcare based on age. We've covered that there are other ways that we could ration healthcare. We've also covered that this topic really only is discussed semi-seriously whenever we're in scarce economic times. But I think it's good to think about it when we're not in scarce economic times, because as our population ages, we're going to have more and more people who are older, of course, and age is probably one of the greatest risk factors for many of these diseases. So it's something we're going to have to think about and face at some point, if not now, if not yesterday. So in your reading, Why We Must Set Limits, I ask you this. When Callahan's book Setting Limits was first published, it was considered quite controversial. What are the main points of his argument, and what would society look like now if his recommendations were implemented? After you take a look at the reading Why It's Time for Healthcare Rationing, take a look at this question. Ubel claims that the need to ration healthcare created managed care in the United States, but that managed care alone is not a sufficient solution to scarce resources. What alternative approaches to rationing does Ubel suggest? And if you think of managed care, think of your HMOs, places like Kaiser, or maybe you have health insurance where you have managed care, so that you have a primary care physician and that person is in charge of coordinating your care. And you can't go see a specialist until your primary care physician gives you permission to do so. So that's a little bit of an example of what managed care is. And it has been shown to be a cost-saving approach to healthcare, but it's not sufficient to meet the needs of scarce resources and the growing amounts of people that need healthcare. Your next reading is called The Pied Piper Returns for the Old Folks. And the author argues that Callahan's proposal is class biased. That is, it discriminates against the poor. Do you think this argument's convincing? And does the author's point, if valid, destroy Callahan's argument? And reading 19, From an Ethics and Rationing to an Ethics and Waste Avoidance, Brody asserts there are two principal ethical arguments for waste avoidance in medical interventions in healthcare. What are these two arguments, and what are your thoughts about their implications if they're to be taken seriously? Reading 20, Aim not just for a longer life, but expanded health span. So hopefully you've covered the concept of health spans thus far, but as a reminder, it provides a different way of thinking about longevity than does increased life expectancy or compression of morbidity. So what do Perry and Butler mean by health span? So hopefully this gave you a little bit more information on things that you can think about when thinking about healthcare rationing. So what do you think? Good idea? Worth exploring? Bad idea? Let's not talk about that anymore. And if it's a bad idea, how else can we start thinking about how to meet the growing needs in healthcare for a population that's growing, meaning the older adult population, in a way that is fair but also takes into consideration that we have just so much resources. We're hoping that you guys will solve this problem.